Hello, everyone. Welcome to another episode of the Epidemic Ethics webinar series organized under the Global Health Network. My name is Teck Chuan. I'm an assistant professor with the Center for Biomedical Ethics at the National University of Singapore. So I'm really pleased to be chairing this session today on restricting population movement during COVID-19 ethics and justifications. So I guess we are all living under restrictions in one way or another. So it's a live topic. Different countries have different rules. There's no particular universal playbook. So really important that we discuss the ethical considerations and principles for maintaining restrictions, lifting them, or reimposing them, and for whom. So whether it's only vaccinated people or everyone, and in what context, whether it's the domestic context like eating in restaurants, or in the international context like international travel. So we have three great speakers today, panelists with us, and I'll just introduce them very quickly. We have Dr. Roberta Andregatti, who's the Regional Advisor on International Health Regulations at the Pan-American Health Organization, PAHO, and she has a supporting role as well to the WHO focal point to coordinate the collaboration between WHO and PAHO. Second, we have Ms. Martina de Folco, who's the Policy and Engagement Officer for the Oxford COVID-19 Government Response Tracker, and she has a sociological background. And lastly, we have Professor Ruiping Lei, who is Professor and Executive Director of the Center for Bioethics at Hua Chong University of Science and Technology in China. So different speakers from different parts of the world to share their perspectives and views and insights with us. Before I invite Dr. Andregatti to speak first, just some housekeeping. So we'll be using the chat function just to say hello and to maybe to introduce yourself if you'd like to. If you'd like to raise questions to any of the panelists, please use the Q&A function. And if you like the questions, if you want to see a question being answered, please click on the like. And so we'll understand which question to prioritize. And lastly, please note that the seminar will be recorded and will be made available on the Epidemic Ethics website later in the week. Okay, everyone. So without further ado, Dr. Andregatti.
Yes, good morning, good afternoon, good evening. And I'm going to share a few slides with you. And I would like to make clear that for me, participating in this seminar is like being on the verge of an abysm, is like facing my demons, because during this pandemic, us as public health practitioners, we have been torn by many difficult decisions. We have been witnessing a decision that from our perspective, we were left baffled. And then I'm here also for educating myself, and thank you for your patience if some of the issues that I'm going to be raising are going to be very, very rudimentary for you as a community of ethicists. Just to start, throughout this pandemic, but also before, as a public health practitioners, I think I've been witnessing and being caught into the dilemma of clinical ethics, the freedom of the individuals versus public health ethics, the well-being of the population beyond the individual. And in many discussions that I've been involved with in facing a primarily public health response, the inputs that we receive from the ethicists were really, in my opinion, driven by a clinical ethics perspective, the individual perspectives. And then I started asking myself a lot of questions. First, if population's health is an ethical value, and how do we characterize it? And if measures that we might adopt to improve population health are regarded as an ethical value by you guys ethicists. And also, do we assume, to what extent are we assuming that national and international legal instruments are founded on ethical values? Why the application of certain laws is regarded as unethical? How do we dig into whether a legal instrument is founded on ethical values or not? And to the extent to which public health measures are not exacerbate inequities, can they be regarded as ethical? And the last question that it comes from before the pandemic is, are the ethical analyses to which we are exposed as public health practitioners conducted on good science? And I've put on the table the very blatant example of the call of ethicists to cancel the Rio Olympics, which was during the Zika emergency, and which was a call which was based on a fundamental, on ignoring the fact that the vector during the winter time in the southern hemisphere was not even there to transmit the virus. And sorry, I have a sirens on the background. And these are basically fundamental questions that we have been facing from before the pandemic. Then going to the questions that were shared with us panelists, I guess, the first question was whether in the context of high COVID vaccination rates, broader restrictions, including lockdowns, can be justified. And technically, yes, and we captured these yes in a guidance document, WHO guidance document that was published mid-June, since the criteria that should inform the adoption of public health measures are the intensity of transmission, the epidemiological situation in each jurisdiction, and most importantly, the capacity of the health system, and in particular of the health services. And then, and overall, the implementation of what can be regarded as more or less restrictive measures of the individual freedom of movement depends on the risk tolerance of national authorities or local authorities in the context of a national response strategy to the COVID-19 pandemic. And here the question to me is not really, is it, are the ethical, are broad restriction justified or not? We are 2 years into this pandemic, and the critical question for me, is it acceptable, or ethical? I don't want to be saying heresies, but is it acceptable that at this stage there are still countries that have not, or locations which have not been able to increase their health services capacities? Then regarding the ethical consideration associated with the use of targeted restrictions and lockdowns. In the document that I mentioned earlier regarding public health, the adjustment of public health measures that was published mid-June, yes, we are, WHO is contemplating the application, the adoption of individualized public health measures based on someone's immunity status. And such individualized public health measures, in the sense of measures that would be granted more, quote, freedom to the individual, more social integration of the individual should be based, the decision to go for them should be based on the ability and presence in the location, in the jurisdiction of robust public health measures, where robust public health measures span from the adherence to personal protective measures to the respect of distancing in public places, and the adoption of such individualized public health measure would be based on the assumption, because it's still an assumption, that the risk of infectiousness of vaccinated individual is lower. They are, quote, less infectious. And the considerations that we are offering to guide on the adoption of individualized public health measure, we encompass two areas: ethical considerations and technical considerations. First, just to be clear on the technical aspects, there are still very many unknowns with respect to the effectiveness in real life of the vaccines, of different types of vaccines. We are still, as you can see, at least already from the newspaper, there is a debate and there are changes in policy regarding the vaccination schedule. And most importantly, we still do not know for how long the immunity, both naturally acquired or confirmed by a vaccine, is going to last. This is work in progress. And in such a context of work in progress, we are in the middle of a pandemic, and if we recognize the existence of a pandemic, of a situation of concern, life cannot be as we wish. There are certain changes, certain behavioral changes that we can make. And now if we move to the ethical considerations, and here is where I'm not sure whether the technical consideration, what is labeled as ethical considerations, they are perfectly aligned or compatible. First, the ethical consideration before applying individualized public health measures. And in the individualized public health measure, I'm including those who would be granted more freedom of movement to the individual, but also on the other end of the spectrum, the obligation making a vaccination compulsory. And which from our perspective, as public health physician, we regard it as of course, from the public health perspective, as an acceptable option. Now, if we look into the providing more freedom, what we are promoting in that document is a proportionate and inclusive approach that should can be implemented in the presence of reduced barriers to access vaccination, and should also consider measures for non-vaccinated individuals alternatives to being vaccinated, like reliable COVID-19 test results. And here is where in the same document, or in the same set of WHO document, we are not perfectly aligned between ethicists looking more into the individuals and public health looking more at the population. Because, for instance, a test result, a negative test result is valid the moment the sample is taken. 3 hours later, the situation of the individual vis-a-vis being infected or not might change. And also in the consideration for non-vaccinated individual, this document is proposing to issue immunity certificates when as I mentioned before, we do not even know for how long the immunity is lasting and what kind of correlation between infectiousness and immunity is. And also, when implementing individualized public health measure, consideration from the ethical perspective should be given to exemptions like recording and verifying and recognizing that certain individual for medical or other reasons might not cannot be vaccinated, and therefore there should also be a way if individualized public health measures are adopted to recognize this status. And also there is the recurrent issue during this pandemic of the collection, storage, and use of data that for ethically justified purposes. And my questions when we were reviewing that document that eventually got public is, what is an ethically justified purpose? Now, moving to the third question that we were asked to comment upon is whether profound inequities in vaccination coverage internationally, in that context, what are the ethical considerations associated with the continued use of travel restrictions? First, I was a bit baffled by this question because are all international travel-related measures regarded as restrictions, and how is the restriction defined? Now, I do recognize this semantic confusion because before this pandemic, we didn't have a taxonomy or the adequate semantic to define the word of public health measures. And we basically started to develop that kind of taxonomy in May 2020. But still, I had the sense from this question that any international travel related measure is regarded as a restriction, which I don't think is the case. And overall, in the two policy and technical documents that were published in July regarding the considerations for implementing international travel restrictions, our main goal from the public health perspective is that any decision related to travel measures should be driven by the overall health and well-being of community and of communities. And then implicitly we are saying, yes, it cannot be a win-win situation. An individual who wishes to travel might not be able to do so. And not be able to do so because what we are advocating, we are inviting national authorities to do is to adopt a risk-based approach in shaping their international travel measure policies, and most important, and the set of measures that authorities might adopt depends on the risk tolerance of national authorities. What certainly, what we do not recommend is the requirement of proof of vaccination against COVID-19 as the only and exclusive pathway or condition permitting international travel. We are inviting to, yes, use a proof of vaccination as a tool to lift, adjust measures, other public health measures upon arrivals or prior to departure, such as testing and requirements. And the reason why I've circled this in red is because, again, as public health practitioners, we were driven in recognizing or putting on paper the lifting of measures such as testing and quarantine, when in fact, technically, there is no reason for justification for testing as a measures for facilitating international travel. And now, after the pandemic or still during, I think that my personal and other colleagues' challenge is whether we will be ever able to realize when we are dealing with an ethical issue and when we have to liaise with ethicists, and how can we learn to work hand in hand in peace times with ethicists and public health practitioners, because we are bumping into this kind of issues only in situations like this one. Thank you very much for your attention, and apologies for having been long. Over to you, Chairman.
Andregati. I mean, it's a great overview of all the issues, and also for sharing some of the WHO positions. I think the last question is so important. How can ethicists and policymakers work together? Essentially about thinking about how ethics could be better embedded into policies. So I just leave that for food for thought for everyone. I just call upon Professor Lei Rui-Ping to speak next. Prof. Lei.
Yeah. Sorry, I can't log in my mailbox, due to I input the wrong password many times, so I can't send my PPT slides. So hello everyone, it's a great pleasure for me to be invited to participate in this epidemic ethics webinar. So I think tonight I want to talk about the the strategy in China to the COVID-19 epidemic. And it's this strategy, China's zero clearing strategy to the COVID-19 epidemic, can be ethically justified. So I want to focus on this topic. Nowadays, I think the situation is changing and changed, especially with the high coverage of COVID-19 vaccination. But I think, some basic ethical issues we need also, still take into account. So firstly, I will give a brief introduction about this strategy of zero clearing in China. This strategy, is an approach to COVID-19, which aims to eliminate the virus wherever or whenever found by using public health interventions, including vaccine, to separate the virus from humans. It gives the virus no opportunity to survive in human body or mutate into a new variant. So once a first case is confirmed, then contact tracing to find the close contacts and lock down the middle and high risky zones, and lift lockdown if no new locally confirmed cases for 14 consecutive days, and also using local or whole-scale surveillance testing repeatedly to find the positives. And the first step is, generally, is treating the cases with symptoms in isolation and quarantine the cases without symptoms and close contacts. So that's, I think, after the outbreak of COVID-19 last year, in Wuhan, I think, that's a basic strategy in China to prevent and control this epidemic. And fundamental ethical issues, I think in public health, it's public health ethics, the basic ethical issues. In this sphere, I think we need to talk about So it's protecting public health, during the, especially public health emergency, entails in infringement of individual freedom at a different degree. So that is, we have to, in this, when we confront this public health emergency, we have to balance and weighing the different values. There's two values: public health, this is a public good, and individual freedom. And in balancing, there are 5 principles, basic principles, we in public health ethics we have to uphold. First one is effectiveness or utility. That's a net benefits of the public health intervention. We need to, calculate, we need to weigh and, balance. And also proportionality of the intervention with limiting individual freedom. And the third one is necessity for protecting public health. And the fourth is the least infringement of individual freedom. And the last one is transparency of this decision. And I think that's the 2 essential aims of, the clearing zero strategy. One aim is to prevent the virus from the contact with humans and force it to stay in the external environment and die away. And all basic public health interventions, such as wearing face masks, keeping social distance, washing hands, and the sterilization of the environment, avoiding to join mass gathering, and so on, are for that purpose. This is all of this unavoidably limit individual freedom. And I think, in our history, human history, we, went through many plagues and epidemics, and, without vaccination. But, finally and ultimately, we control the plague, the epidemics. I think that's just relying on this basic public health measures and public health interventions. And the other aim is developing vaccine and applying it to humans to build herd immunity, which would build an immune barrier to block humans to be infected with the virus. However, so far, I think, even though we have different kinds of vaccines, but all developed vaccines in use are only able to build an immune barrier for a part of the people, but may elevate the symptoms for other part of the people, but it cannot avoid, this is the infection due to the different kinds of reason. And so the first aim is still necessary and more basic. So the lesson, I think, in this COVID-19 epidemic, I think for many countries, is to ignore the fundamentality of the first aim in public health. And also major ethical issues in, I think, is clearing zero approach. But I think due to the time, the limit time, I only pursue 2 or 3 ethical issues. The first one, the ethical issues, raised by this strategies, this approach, this is the use of health certificate, this app, for contact tracing and reopening. This is a ethical issues raised by this digital, this is driven approach as a new public health measures. We once, wrote a paper, an essay, but I think tonight I don't have enough time to pursue this point. And the other major ethical issues is as follows: differential treatment to 3 types of zone. In China strategy, we classify different type, this according to the risk level. So that is, how to justify this kind of differential treatment. And the second, is the large scale or whole scale. This is nucleic-based testing. This is if we have enough time, And also this lockdown, a local or whole city lockdown. This is a strict restriction. The first one, this how to justify the differential treatment. In China, all communities where the people live are classified into 3 zones during this epidemic. But this is, adjusted, from time to time. It's not, it's according to the epidemic and according to the, gathering outbreak, this different situation. And high risk zones is, according to the number of cases exceeded 50. This is a cumulative number of cases, confirmed cases. And also this gathering outbreaks occurring within 14 days. That's, the criteria for this classification. And also middle level, middle risky zone. This is according to the number of new confirmed cases did not exceed 50. And, there were no gathering cases within 14 days. And the lower risky zone is according to, this is a criteria, it's a no confirmed case or no newly added confirmed cases within 14 days. This is in lower risky zones, people can freely travel with health certificate and freely enter all kinds of places such as supermarkets, entertainment places, restaurants, only with wearing a mask and being, measuring a body temperature. And middle and or high risk zones are partly locked down. The people are encouraged to stay at home. And the exceptions include those who have to work, go to school, or visit the hospital outside the zone. All confirmed cases have to be moved to hospital for treatment in isolation. And in last year, Wuhan is a whole city. This is lockdown. But after that, this is different cities. According to this different criteria. This is not, this is no whole city lockdown. It's just a partly a lockdown according to, the different criteria. And also the positive cases without symptoms or close contacts will be moved to special sites or at home to be subject to medical observation. And they have to be observed for 14 days and tested for 3 times, and 2 for nucleic acid testing and 1 for this antibody testing. And entertainment places will be temporarily suspended, and the strict health surveillances for factories, companies, offices, schools, airport, train, bus, this public transportation area, and other open sites will reduce meetings or other gathering or reduce admissions, and no visitors to hospitals, kindergartens or nursing homes. This is strictly protected. And all persons will be subject to mandatory testing. And after 14 days, no new confirmed case is detected. This zone will be changed to lower risky zone, and the lockdown be lifted. And are all these measures in this differential treatment ethically justified? I think we published an essay in Bioethics Forum by Hastings Center, and just briefly summarize. This is the main point of our justification, and it's necessary and useful to limit the transmission of the virus within the community and spill over to other parts of the city or to other cities. And in middle or high risky zones, the measures of limiting individual freedom are severe, putting the great burdens to the residents. The people pay the material and mental costs in depriving their personal freedom, to some degree. However, I think, the benefits are also great and cannot be obtained in any other way, and no other measures could bring such great benefits to us. The benefits may outgrow the burdens. We may say that the freedom limiting is proportionate with the benefits. And also, this is the classification of different zones, and also this is the decision the process. It is transparent to the public. And also, this is a large scale or whole scale nucleic acid testing during this is lockdown, and also especially in the middle and high risky zones. So this kind of large scale and whole scale testing be ethically justified or not. In China, many cities conducted this approach, this strategy to find the confirmed cases and the positives. I think the benefits of this large scale and whole scale testing are to detect newly infected cases and help the epidemic control agency to know the scale of the virus transmission. And on the basis of this epidemiological information, the agency may adapt its programs and policies on public health interventions and reopenings, including intensifying or relaxing the measures to limit citizens' freedom to the real world. So the costs were high, but the benefits from wider reopening would outweigh the costs which is paid by the government. I think, the benefits include, as follows, limiting the spread of the virus with timely treatment of the detected positives, so avoiding the harms to public health. And the second, promoting the reopening and economy. And the third one is reducing the limiting of individual freedom. The only mandatory interventions are just wearing masks, measuring temperature, keeping social distance, and avoid mass gathering. This is, high risk zones, only, 2 sites, and middle risk. This is, 18 sites. This is in different, this gathering outbreak. We classify the different risk level zones. And also the lockdown. Yeah, the lockdown of a city can be ethically justified or not. Because at that time, last year, I'm in Wuhan. And so this is not just this is ethical analysis, and also this is a personal experience. So if the transmission of the virus in a city is so wide that it is highly possible for the virus to spill over to other cities, it is time to lock down for the reason to protect public health of other cities all over the country, as well as, native city. I think this is a example of the lockdown of Wuhan. We can, according to some, the statistics, we can.
Properly, can you hear me? Sorry to interject. Yeah? I need to move on to the next speaker because we've got so many interesting questions to ask. Thanks.
Okay,
so could you wrap up in quickly? Thanks.
Just to summarize, I think, so I think, this is quickly reviews the lockdown of, in Wuhan. This is 76 days lockdown. But I think, this is greatly reduced the transmission of this is new virus. And also Wuhan, this is after 76 days lockdown, this is a successful reopening and restart. So I think that's also an example, I think, experience to support, to some extent, the justification for this kind of, lockdown strategy in, specific time. This is a contextual analysis, and also this is, this is a balance and weighing the different values, in specific time. So I think, so much for this, and I look forward for the questions and discussions. Thank you, Chair.
Thanks, Prof. Lei, for sharing the rationale for China's zero tolerance approach, and also the very interesting idea of differentiated treatment or differential treatment by zones as opposed to individual vaccination status. So we'll talk about that a little bit more later. A couple of questions on that. We move on to the third speaker, Martina Folco.
Yep. Hi, everyone. Pleasure to be here. Let me just share my screen so that we can get cracking, and I will try to be extremely brief. Hi, everyone. Pleasure to be here. I am Martina Folco. I am the Policy and Engagement Officer for the Oxford University COVID-19 Government Response Tracker. And my presentation will focus mostly on our research on stay-at-home orders and some food for thought for our discussion today. So, as I said, I will first introduce our project, and I will briefly describe to you our indicators on closure and containment, which includes stay-at-home orders. Then I will share some insights from our research on stay-at-home orders, aka lockdowns. And finally, I will consider briefly the first question of today's seminar, which is, can lockdowns be justified in countries with high vaccination rates? So first of all, very briefly, our project is a database on government responses to COVID-19. As of now, we have 23 indicators, and we provide a systematic cross-national, cross-temporal measure of how government responses have evolved over the full period of the disease's spread. And our database helps to answer these two critical research questions. What leads governments to adopt different policies? And what effects do government responses have, and how do effects vary across different populations, countries, and contexts? As you can see here from the table, we have 23 indicators that are dedicated to closure and containment, economic response, health systems, and vaccine policies. They are recorded on an ordinal scale to capture not just the presence, but also the degree of the response. And we have 5 simple linear indices that are normalized to vary from 0 to 100. And you can find our database freely online on GitHub and also on the Blavatnik School of Government Research Project pages. So a spotlight on closure and containment indicators. We have 8 indicators in that in this area, and all indicators but C8 have an additional binary variable recording whether the measures are applicated on a national level or targeted or regional. And our data set records stay-at-home orders on a 4-level ordinal scale from 0 to 3, indicating the strictness of the policy from which, and we use in our research that I will share today, levels 2 and 3, which indicate a required closure of either certain sectors of society or full closures for the entirety of society, as in, for instance, what happened in Italy in the first wave. Obviously, we use a very expansive definition, which brings some limitations to our approach, because when we discuss stay-at-home orders in our data set, we include in this category the reported, for instance, the reported militarized lockdown and arbitrary arrests in Rwanda, but also a simple nighttime curfew in Zimbabwe. So there are limitations to our approach. And now from some emerging patterns from our research, I'll go into this in more detail on the next slides, but very briefly, the big patterns that we've seen over the pandemic are first, that initially all countries converged on a similar set of policy actions. In the middle part of 2020, we saw countries start to diverge, and regionalization played a big part in this trend. Over time, compliance with very stringent policies has fallen. And finally, going forward, we've seen a sort of path dependency in how countries continue to respond to the pandemic. So very briefly, in this graph, you can see that in the first months of the pandemic, the best predictor of policies is simply time. We found that there was a global bandwagon effect where almost every country implemented stringent policies at the same time, regardless of local conditions. So in this chart, every row is a country. The blue that you see there is whether the containment and health index that we code was above 50 on a scale from 0 to 100. And the red indicates if the containment and health index was below 50. And the white diamond dots are the first deaths of each country. And as you can see here, there's a remarkable alignment in mid-March before most had even had their first death. But there is much more variation in the coming months. So country policy becomes more shaped by domestic epidemiological and political factors rather than anything else. And here you can see the regional trends in the use of stay-at-home orders through to March 2021. And this is the proportion of countries in a region, so Africa, Americas, Asia, and Europe, with the stay-at-home order. Despite early alignment, you can see in the middle of last year, around the Northern Hemisphere summer, Europe basically stopped using stay-at-home orders. Conversely, stay-at-home orders and curfews remained quite popular across the Americas, largely driven by Latin America. Here you can see the path dependency that I was talking about. So basically, here we have 4 countries, starting with the Philippines on the upper left, then the UK, Australia, and finally China on the bottom right. On the x-axis, there is the date, and then the case count. So how many cases of COVID there were in the countries are in the y-axis, and the red bars are periods of stay-at-home orders through to March 2021. Each dot shows you the case count when a new stay-at-home order was introduced, one of the last resorts in a lockdown toolbox. So the trend here, we can see kind of 2 emerging trends. The trend for the Philippines and the UK is consistent with the idea of desensitization. It takes more cases to trigger a lockdown. The Philippines had the first lockdown with 5 cases, followed by the second 560, and a third one at 2,500 cases. And the United Kingdom followed a similar trend by instigating the first lockdown with 1,000 cases, followed by 20,000, and followed by 25,000. You see a reverse trend in Australia and China. So they become hypersensitive. It takes very few cases to trigger a lockdown. For instance, Australia had their first lockdown at 330 cases, followed by 63, and then 20, which is not on this chart. In the next slide, we'll look at this for all countries that had multiple stay-at-home orders, but the y-axis will be relative to the first one. So the first lockdown. So if you like, every country's first dot will be at the 1 on the scale, and the next dot will be either higher or lower than the first one. So as you can see here, almost every country follows the general trend of decreasing sensitivity. Subsequent lockdowns occur at 10 times or 100 times as many cases as the first lockdown. There's very few exceptions. But you can see some of them very well on the right side of the graph, where we have the blue countries, which are those that had relatively lowest levels after April 2020, less than 100 per day. And if your countries that largely contained the virus in 2020 have become hypersensitive, like China, Australia, or New Zealand, meanwhile, countries that have not contained the virus very well in 2020 appear to be largely desensitized to their case levels. Case in point, the UK. And now, finally, I would just like to offer some insights on the first question of today's seminar. So can lockdowns be justified in countries with high vaccination rates? Obviously, I am neither an epidemiologist or an ethicist, so I offer my insight as a sociologist and coming from the research that we do at the tracker. So to discuss the question, I would first ask, how do we define high vaccination rates? 51%, 90%. So as you can see from my slide, a lot of countries have very different ways and very different percentages when it comes to vaccination rates. So the US has 57% of fully vaccinated, Germany 66%, and finally the United Arab Emirates 87%, which is the highest vaccination rate in the world. So according to different definitions, we could discuss different scenarios. There are also very high variations within the same country. So you can just look at the difference between the Northeast and the South of the US. So the states there, depending on their region, are doing very different when it comes to vaccination rates. And to make a comparison with another virus, to put this into perspective, reaching the so-called herd immunity for measles requires around 93 to 95% of the population to be immunized. And the CDC, the US CDC, has said in July that the Delta variant is around as contagious as chickenpox and measles. So what does this mean in terms of lockdowns or other forms of movement restriction? Basically, if we define high vaccination rates as 51%, the people susceptible to infection that are unvaccinated are still a large part of the population, which can lead to exponential rise in cases and the health and test, trace, and isolate system to be overwhelmed. And if we use the measles comparison, no country will qualify as safe in this case, not even the UAE, which has 87% of vaccination rates, just because that threshold for so-called herd immunity has not been reached. For instance, in Italy, we have a measles vaccination rate of about 98%, but as soon as it drops just a little bit, like to 97.8, politicians start getting worried because they start getting worried that there might be an outbreak. And the second aspect that we should look at is the incidence of infection. So even in a country where almost everyone is vaccinated, letting the virus circulate freely might bring severe consequences in the long run, which should be considered. So the more a virus circulates unhindered, the more it mutates. In a country with a significant amount of population immunized, this can mean the development of vaccine-resistant variants that would make the effort a lot of countries have made virtually useless. Already with the Delta variant, there were concerns over how much available vaccines would be able to be effective. As new variants emerge and become dominant, this will continue to be an issue. And related to this problem of how long, related to this issue of new variants, is also how long immunity lasts. So in the case of some vaccines, such as the one for measles, immunity after the boosters is lifelong. In other cases, such as the flu, and as we know now, COVID, immunity significantly decreases after about 6 months. Now we'll have to see what the effects of boosters being rolled out is going to be. But it's not certain that they're going to last for life. And in countries, even in countries that have a high vaccination rate, if an outbreak occurred when the population immunity was at its lowest, it could give way to an exponential growth of cases, leading to hospitals being overwhelmed and a lockdown becoming necessary. Another factor we should consider is also the strength of a country's healthcare system, and also its test, trace, and isolate capacity. In most countries, such as Italy, during the first wave, a lockdown was necessary because we did not have an updated pandemic plan. We had virtually no PPE stock. We lacked critical equipment like ventilators and ECMO machines, and our healthcare system was already understaffed. Other countries, such as South Korea and Japan, never imposed a lockdown like the ones in Italy or other parts of Europe because they have efficient pandemic protocols due to their past experience with other recent pandemics, such as SARS, and a very strong test, trace, and isolate system. countries that in the course of the pandemic have not solved capacity issues might still need to resort to lockdowns if the situation worsens enough. And this is, of course, a problem for countries that do not have the capacity for that kind of investment, which brings me to my final point, and then I'll finish, is that pandemics are a global phenomenon. In the end, it won't matter if, for instance, Italy has a 95% of its population vaccinated, because the virus could arrive from abroad and first wreak havoc among the most fragile among us who could not get vaccinated. And then perhaps mutate enough to be able to resist the vaccines that we have. And this is why a global effort in vaccination campaigns is vital to end the pandemic and render lockdowns useless, and for us to move beyond them and leave them behind us. And as of now, obviously, as you know, only around 4% of people in low-income countries have received at least one dose of the vaccine. And this brings me to the end of my presentation. So I've included some links if you want to read more about the research cited. Also, if you want to consult a great project that two of my colleagues helmed, which is a vaccine equity dashboard, which we did in partnership with UNDP. And I can include the link in the chat if you so wish. And thank you for your time and for listening.
Thanks, Martina, for sharing the Oxford COVID-19 government response trackers work. I'm going to jump straight into a question that is raised by one of our audience members before the seminar, and it's a question for all three panelists. So the question is this: so we know that some governments are they want to achieve high vaccination rate, whatever high means, and one way to do this is to sort of employ a vaccine mandate approach. So you can require people to be vaccinated in order to access work or even to access their workplaces. One of the questions being asked is whether or not this is an ethical kind of tool. And if not, how can ethicists bear in on the debate to ensure that human rights, I guess in this case to work, are not violated?
And we have seen how difficult the decisions are, and we have learned, or we should have learned by now, that any decision has a multifaceted aspect encompassing different sectors. And one point that, at least in the WHO region of the Americas, we have been stressing is the involvement of the bioethic committees in the decision-making process, and bioethics committees that traditionally, when present, they are involved in the determinations related to treatments for individual patients. But now we have seen that in this pandemic decision with where ethical implications should be taken into account goes beyond, again, the individual, the patient, and span to the society. Then it would be a matter of involving the bioethics committee and also gearing up to expand their mandate and their scope of action. This is just to start with. Over.
Maybe I can comment as well, briefly. So unfortunately, it is true that in pandemic times, some governments have used the emergency laws, for instance, to kind of boost their powers, like Orban in Hungary. And it is true that in some cases, the laws being passed are creating very high inequalities and are at times violating human rights. So it is difficult to make a blanket statement for every country because there are such different political regimes in most countries. And so I am not comfortable saying, oh yes, like restrictions for people going to work should be in place and that's it, because there are some contexts where that is not very much advisable. In the context of, for instance, European countries such as Italy, what the government has chosen to do is not to make the vaccine mandatory, but to make the vaccine pass, or the so-called green pass, mandatory to enter work, which means that you should either be vaccinated, or you should have had a negative COVID test within 48 to 72 hours. And that is because in most constitutional countries, it is pretty much impossible to impose a vaccine mandate for adults. And that's why it is done for children. So children, being minors, do not enjoy the full constitutional rights, but adults do. And so this is why governments have been using these green passes, which are basically a mid-step. Like, they're not mandating it, but they're also encouraging you very forcefully to take it. And so unfortunately, as long as the pandemic goes on, and as long as we have very large sectors of society that refuses to take the vaccine for misinformation, doubts, ideological reasons, then I'm afraid that restrictions of the sort will inevitably keep getting enacted.
Yeah, I also want to give some brief comment. I think, when we talk about, the strategy to this is a public health emergency, I think, this is we need to take into account these fundamental ethical issues in public health. Is how to balance the two values, between the two values. No absolute values always in priority, or we should always put one value in high esteem as usual. I think this is the two values, public health and individual freedom. We'd have to make trade-off, sometimes we'd have to make balance. And also, I teach, applied ethics and bioethics in our university for many years, and also to some foreign overseas students. We always talk about, at the first beginning of this class, this what is ethics about? Yeah, it's this is to identify good and evil, or right or wrong. But sometimes ethics is about to make choice between the lesser of two evils. But we must make this kind of choice. So I think especially I think the speakers tonight give very, I think from the theoretical and ethical perspective and ethical analysis, and also this is a very well-founded statistics. But I think we also need to take into account always we make this a retrospective analysis. Is is an easy job, but the difficult thing, the tough decision. For example, last year, in January 21st, in Wuhan, the situation, how to make this choice and how to make the decision. It's a kind of prospective, decision making. It's we don't have this retrospective, data and statistics. This is unknown at that time. So I think, we need to take into account the context, when we make a decision. And also I think when we make a balance is two values, and also we need to take into account, not just government powers, and also, how the government takes the responsibilities. For example, in China, I think Chinese government from the first beginning, from the outbreak of this, pandemic, the government took the public health responsibility, I think, including, this is, now is, we have universal access to vaccination, and also including the booster injection. And also this is the free charge, medication during, the pandemic for the confirmed cases. And also this is a free charge, the testing. This is a large scale and whole scale nucleic acid testing for all the, this is affected, area, this is the resident. And also, during the lockdown of, Wuhan, it's not just, this one policy lockdown, and also this is a comprehensive support system from all the country, including this is, over 40,000 medical professionals from all over the country, to Wuhan and to give support. And also this is a volunteers, and also this is a civil servants, to dispatch to the different, residential, every residential communities, to establish this very good, food delivery, and also, some medication delivery system. This is the whole system, support system, not just, this is, let it alone. And this is just, in the lockdown. This is a restriction, the freedom of the people. I think, it's not an easy job. It's not an easy job, especially in this, public health emergency. And also we need to, to take into account, this is a individual. The role of individual is different from, this is usual situation. This is in public health emergency, especially in this emergency. Everyone, you have two roles. Everyone, might be a victim infected by the virus, and also everyone might be the vectors of the virus. So I think this is a totally different situation. So I think the balance, this is the weighing between the two values is, and also according to a different context, according to the different situation. So that's, I want to make this brief comment. Thank you.
Okay, thanks everyone. It looks like we might have run out a bit of time, but I'm just going to extend it to about 5 more minutes because we've got some really important questions in the chat. One question is for Prof. Lei, and we're wondering whether you can just answer this very quickly. The question is whether or not you think COVID, China's zero tolerance policy, whether or not there might be a risk of it, in terms of isolating it from the rest of the world, if you were to pursue this strategy when the rest of the world is pursuing a more endemic, living with COVID-19 strategy. So very quickly, your thoughts on that.
Yeah, that's a good question. But I think when we talk about, we will, maintain this clearing zero strategy in China or not, I think also now we have, good discussion now in China. I think not, I think in the near future, we will, adjust. But, this is what is the right time and the correct time, because I think we need to notice the different situation in China, because from the very beginning of this pandemic, we adopt this very strict strategy due to, this is the outbreak, in Wuhan. So this it's not easy, from one extreme, suddenly to the other extreme. So we need to transform, gradually adjust to, this is maybe different, strategy, but we need, maybe much more careful about, some adverse, effect, because we adopt this strict strategy. We can call it a wartime approach. And maybe many other countries, it's a peacetime approach. But I think with this strict strategy, so it's the whole population in China, we have very, low, contact to a virus and a very low antibody level. So I think, the whole population is more fragile to this, especially the virus, variant. For example, this is a Delta invasion in China in this July, August, and also, this is at the end of October. So I think we need, I think maybe the similar situation in China and in New Zealand. I think now, New Zealand, the strategy, from one, extreme strict strategy, suddenly, to this transfer to this is, this is open up. I think we can see that's not a good example, in my opinion. We can see the, there's a rapid, growth of the infected, confirmed cases. So I think, this is a different situation in different countries. So we have to, it's just to adjust and to calculate and to balance, the different the specific situation in different country. I think no shortcut answer. Thank you.
So I'm going to give you one last question, and it's addressed to Martina. Maybe Dr. UntiTitled can also respond. And the question is this. So you mentioned in your research that a lot of countries seem to be jumping on a bandwagon and being sensitive, and the different sort of sensitivity to different sort of case numbers. I'm just wondering whether or not, to what extent those are influenced by political pressure from residents of the particular country, and to what extent should these should scientific and ethical considerations sort of be balanced against this political pressure, if any?
That is I think that is definitely the case. So in the beginning, everyone was scared, and we didn't know anything. So most governments acted like emotionally and just closed up everything, even though, for instance, I think the IHR regulations of the WHO, for instance, prohibit states from just shutting down travel from certain countries. But no, it wasn't that. What was it?
No. The IHR were poorly applied. Okay. Starting from ignorance from within the WHO Secretariat. In Article 18 of the IHR, there are a list of measures that can be applied, and among those measures, there is closure of borders. And for some reason that I know from within the Secretariat, we have created this mystic that the IHR do not allow for closure of borders, but yes, they do. And it's just a matter of ignorance or not wanting to apply that provision. And what is being described as an emotional response, yes, indeed, and possibly it was not being aware, but just applying the precautionary principle. And the application of the precautionary principle as something that has completely been missing in the recommendations, especially during 2020 of WHO. And it's just between these beliefs, legends, urban legends, and stuff like that that have been operated. And there's been, I'm very ashamed of what has happened. And one last point that I would like to make, yes, the IHR has been invoked as a as a primary scope to reduce the international transmission of diseases, and is known as basically the cornerstone for now of international public health law. But there are also the Syracuse principles for the interruption of, for the limitation of human rights in the context of emergencies. Then there was also that layer at in the international legal body that could have been invoked to justify certain restrictions, and this has not happened either. I'm sorry, maybe I've shattered some myth, but that's the reality, what is written in the text. Over.
Thank you, and we shall end on that note, for the very enlightening note for the response. Thank you to all three speakers, Prof. Lay, Martina, and Dr. UntiTitled, and to thank you to all our audience. Feedback on the session. And also, please do look at the website if you want to attend future webinars. And of course, you can also always follow the Epidemic Ethics Network on Twitter. So that's all for everyone. Very good evening, morning, or afternoon. Thank you.